Hi everyone, my name's Dr. Fergal Armstrong and welcome to Cracking Addiction. And today we have the wonderful Mr. Tarek Amiri, a close friend of mine and an expert in opioid agonist therapy. Hello Tarek, how are you?
Thank you, Fergal. Thanks for the opportunity. I am good. Yes.
So I think we need to explain exactly the esteem with which I hold you, the high esteem with which I hold you. You were one of the great advocates for opioid agonist therapy, in particular Suboxone,
hmm
when I first came to Australia. And you and I have worked together over a number of years, and you have supported me in my journey to becoming what I hope to think is a competent prescriber of Suboxone. So first of all, where do we start? Well, let's start off with what is opioid agonist therapy, then what is Suboxone, and then take us through the history of your involvement with Suboxone and how you've supported its
Sh-
distribution in Australia.
Sure. Well, first of all, Fergal, thank you so much for the kind words. I think you are very passionate in the treatment space as much as I am. Um, and as you mentioned, I started in this treatment space in 2012, and that was a time when, the opioid pharmacotherapy was not as, accepted amongst general practitioners and pharmacists. And at the time, we had monobuprenorphine Subutex, and we also had the
Yeah,
Suboxone tablet at the time. And at the same time, we had Suboxone film, which were great treatment options or are great treatment options alongside Methadone, which was sort of available for clinicians and patients to be initiated on treatment since the early 70s. However, obviously in
yeah,
the 2000s, when buprenorphine was first introduced in Australia, and as I said, gave patients and clinicians a choice to, be initiated in treatment. As I said, when I first started Fergal in 2012, all jurisdictions, with the exception of South Australia, required medical practitioners to be accredited in order to prescribe methadone and buprenorphine. South
yeah.
Australia had just changed their policy, which you were able to initiate patients on up to 5 patients on sublingual buprenorphine, which was Suboxone, the combination product. And then in 2013, Victoria followed.
Yeah, and that
Uh,
was for 5 patients, wasn't it? Yeah.
correct,
I,
correct.
I remember talking about Strive for Five. Strive for Five was the vaccine fridge temperature that people would say.
Yeah.
But I used to use that phrase for GPs to try and use Suboxone to treat 5 patients. But before we go on about that, I think we need to just take a step back and just let's emphasize that we are talking about the management of opioid dependence, so
Yes.
heroin use disorder, prescription opioid use
Yes.
disorder. And the first drug that was really allowed was methadone, and that was invented, well, it was invented in the 1940s, but
Yes.
its role as an opioid agonist therapy was developed by Dolan Neiswander in 1965
Yeah.
in the States. And then it came in the early 70s to Australia and Victoria and indeed Melbourne. And so there was a cohort of GPs who were very avant-garde for their time, and they were treating people struggling with heroin with methadone for many, many years. And then all of a sudden, unbeknownst to them, in a factory in the UK with a name called Reckitt Benckiser on it, somebody invented buprenorphine. When was buprenorphine invented?
I think buprenorphine, as you know, Fergal, in its early days was an analgesic, and I think it was also in the
Yeah,
60s in
yeah.
lower doses in the brand name Temgesic, and I think at 200 micrograms for acute pain. And then
Yeah.
obviously with a lot of research that was done in the US, I think in France was the first country that launched monobuprenorphine Subutex in 1996 for the treatment of opioid dependence, because as you probably know, and as the viewers would know, they had a big problem with HIV and AIDS amongst
Yeah.
injecting drug
Yeah.
users.
Yeah. So monobuprenorphine was the first product, and that was launched as Subutex pills, wasn't it?
Correct.
Sublingual
That's
pills.
correct.
That was based on the same technology as Temgesic sublingual pills, wasn't it?
Exactly. Yes. Obviously,
Yeah,
just at
yeah,
higher doses.
at higher doses.
Yeah.
What were the problems with mono buprenorphine sublingual pills? What kind of problems did we encounter there?
I think one of the challenges that community pharmacists, spoke a lot about monobuprenorphine was the time it took, because it was all supervised dosing in Australia, and I think we'll
Yeah,
come to that in a moment. But patients had to be in treatment for X amount of months before they were allowed takeaway doses, and that varies to today between the
yeah,
jurisdictions. But that took a long time for to supervise patients. And there
yeah.
was um, you know, the risk of diversion of monobuprenorphine
Mm,
in Australia, and I'm sure in other
mm,
countries. But that is why Reckitt Benckiser at the time introduced Suboxone tablets with the combination of naloxone to
yeah,
deter patients. And that also sort of opened up treatment, Fergal, in the mid 2000s. And then as we moved into 2011, 12, and 13, the Suboxone film, that saved a lot of supervision time amongst
mm,
patients or pharmacists or even, clinics.
yeah,
That were dispensing opioid pharmacotherapy, buprenorphine, and also takeaway doses. It was a sublingual formulation, film formulation, which was very um, uh, in a pack that was very hard to open. So these were the sort of how it evolved over
yeah.
time. Yeah.
So these changes were really all focused on minimizing the risk of diversion, weren't
Yes,
they?
that's
So
correct.
so the whole idea is that sublingual Suboxone film is less easily diverted.
Yes,
And therefore, that allows us to give takeaway doses, which is what every patient wants takeaway doses, yet
correct.
doctors want to be mean, isn't it? There's a tension between what doctors want to
hmm
prescribe and what patients want. Where can you talk to us about that? What's your views on where we set the line?
I think before doctors can choose takeaway doses, I think state and territory policies dictate that. And
Yeah.
I honestly believe that um, a clinician should determine how many takeaway doses are given to their patient because they are the treating physician. They have assessed their patient. They know their patient. And having a therapeutic alliance, Fergal, as you know, as a clinician, you know, more compliance for patients to be in treatment because our end
Mm,
goal is to keep the patient in treatment and focus
yeah.
on their other medical needs if required. And
Yeah.
and I think that that was a barrier to treatment, and it still is. And even in jurisdictions that are less um, lenient um, compared to some of like Victoria and New South Wales, where the clinicians are based on a risk assessment. And as a clinician, Fergal, you can give up to 28 takeaway doses. That's provided that you, in communication with your community pharmacist and the patient, or the dispensing pharmacist, I should say, you can provide that. However, I don't believe it should be in a timed manner. You have to be on the program for X amount of months before you're allowed
Mm,
takeaway doses. I believe that it should be based
yeah.
on risk assessment. The other point I'm trying to make, I want to say is that I hope the policymakers at the state and territories, who I know very well, are not upset about what I'm saying, but my intention is that we need to treat the patients that is in front of us.
That's a very important point, isn't it? Treatment retention is
Yeah,
everything because if you don't have retention and
yeah,
treatment, you will never help the patient. You will never achieve meaningful change.
correct,
So, treatment retention is the sine qua non of
correct.
recovery, and takeaway doses directly impact
Hmm.
upon treatment retention. But I would also argue that the evidence for treatment retention with buprenorphine is very good, isn't it? What are the figures? Can you remember?
I think, well, I mean, I can remember the long-acting injectables. Obviously,
We'll
come
come
to
to
that in a moment, but I think with
that.
sublingual formulation, it's sort of around the 50%. I mean, obviously, it's going to
Yeah,
differ between
yeah,
jurisdictions, but it is
yeah,
high, and obviously, in certain states where takeaway doses are limited and people are working, then obviously the treatment does go down. Retention in treatment does
yeah,
go
yeah,
down.
yeah. 50% treatment retention at 6 to 12 months is actually a very good figure, isn't
Yes,
it?
yes. Yeah,
Yeah,
and
yeah,
and and that's our
yeah,
aim. And obviously the ultimate goal is to um, get patients completely off treatment in a controlled manner with
yeah,
consultation with their healthcare professional. And that could be nurse practitioners or medical practitioners. And
yeah,
it's a holistic approach
yeah,
that the patient is coming off treatment in a very controlled manner. And they are
yeah.
willing to come off
Now,
treatment.
yeah. Now, we both have been very privileged to live in an era where we've seen a paradigm shift
Hmm.
in the provision of opioid agonist therapy in the form of long-acting injectable
Yes.
depot buprenorphine.
Hmm.
Compare that with Suboxone. What's happened?
Well, I think the last 5 years, the word that I have heard the most from all healthcare professionals across Australia and policymakers is that this is a game changer. I think the long-acting injectable
Yeah,
buprenorphine, and we're very fortunate that we have both products in Australia. Um,
yeah,
And that, gave again a choice for patients and clinicians. And I think now people were able to come to their medical practitioner, nurse practitioner, or their pharmacist and get that administered and can travel. And I have heard in my time that, patients could go beyond 4, 5, 6 weeks without, the next
mm,
injection. I mean, people were traveling, especially people who were working, fly in, fly out workers. It just freed
mm,
the patient of going to their dispensing pharmacist or pharmacy and having to take something every day. I and some
yeah,
patients prefer that. And as what I said, I think we are very privileged, and you are privileged as a clinician that you've got these options. In consultation with your
yeah,
patient, you can provide the right treatment for that patient at that moment in time or in their treatment journey.
yeah,
But I think the long-acting injectables have made a big difference. And if you look at the NOPSAID data in the past 3 years, Fergal, now we are starting to see more patients on a buprenorphine containing product than methadone. Um,
yeah.
and obviously,
So,
buprenorphine's
as a
safety profile plays a very important role in that. Apologies.
yeah, no, absolutely. So we'll just focus on that point, right? The safety profile of buprenorphine for me makes it so much easier to choose buprenorphine, um, both as a primary analgesic agent and also as a treatment for certainly things like prescription opioid use disorder and for that matter, heroin use disorder. And I don't understand why there is such reticence to give takeaways for buprenorphine because it is so much more safe than any other full agonist opioid. I mean, it's not without risk, and it's not to be treated lightly, but relative to the other opioids, it is very, very safe. Um, And I was going to say, picking up on the other point that you most eloquently introduced, this idea of depot buprenorphine being a game changer. For me, it has completely changed the way that I converse with patients. So prior to depot, I would be having arguments about the number of takeaways. And it would erode the therapeutic alliance and it would take up time and the patient would be frustrated. I would be frustrated. And it was a very difficult, sometimes there were very difficult conversations that were had. With depot buprenorphine, none of those conversations happen because you give the patient the
Yes,
depot, that's it. And then you can really start having meaningful conversation about meaningful change and meaningful recovery. And also, the depot itself provides for the sustained high concentration of plasma buprenorphine levels that can prevent withdrawals and prevent the
sure.
euphorogenicity of other opioids. And so, I would just emphasize as you say, it is a complete game changer.
And many of your colleagues over the years have said to me, Fergal, that now, that argument that, oh, look, I'm bound by X policy or this guideline.
Oh,
Now we can focus on other medical needs because they
yeah,
are stable. They are no,
yeah,
and obviously the other big benefit, which I think it's important that we mention, is that when the depot buprenorphines were introduced in Australia from a funding model, that made a lot of um, convenience for patients that they could go get their injection administered, and the dispensing fees that were, in Australia prior to 2003, where patients had to pay up to $10 per day for their dispensing of methadone and buprenorphine formulations. That was taken away, which we're grateful for the options that we have and our health system, where now, after the 2023, all medications are on the PBS. And
yeah,
irrespective of what medication, if the maximum you will
yeah,
pay now, which is great, it's $25 for the whole month. Where, again, the other barrier to treatment, as you and I discussed earlier, was the cost factor. That
mm,
paying up
yeah,
to $35 a week or more in some jurisdictions.
yeah,
Um,
yeah. And it was also unregulated, so it would vary between pharmacies and
s-
vary within
Absolutely, and
doctor
private clinics
surgeries as
and
well.
things, it was up to $10.
Yeah,
So
yeah,
this made it
yeah,
a lot easy. So there was no cost barrier, there were no takeaways. If you're on the
yeah,
injection or depot buprenorphine, and then the whole model, funding model, and treatment options, over my time in the last 13 years or so, I have seen many changes, and all, I do believe, all in the positive direction. Are we done yet? I don't think so. Um, I do believe,
mm.
Fergal, that we need policy alignments between all the states and territories. Um, and I think that again,
But that's
sure, please.
yeah, that's a big
Mm,
issue, isn't it? Because we do need to consider how, on a widest
mm-hmm,
level, the differences between states and territories and in how they choose to
mm-hmm.
deliver opioid agonist therapy. So how would you summarize those differences state by state?
Well, I guess it's difficult to put it in summary, but I think, for example, New South Wales and Victoria, any medical practitioner can initiate patients on a buprenorphine, either the sublingual formulation or the injectable formulation, without doing any accreditation training. However, in other states like ACT, you cannot initiate. In Tasmania, you cannot initiate without doing the accreditation training. In Western Australia, you've got to do a 4-hour online module. Queensland, it's an online module, and they've got 3 levels or prescriber levels. But I think these are the barriers again for clinicians that, in order to um, prescribe opioid pharmacotherapy or medication-assisted treatment, various. Then there's multiple acronyms around that. I think these are the barriers that just sort of prevents more clinicians coming into our treatment space. And then obviously we have a shortage of prescribers, as you know. And we've got an aging
Mm.
population of prescribers. And I think you mentioned this earlier about those who initiate, started in with the methadone, they are still practicing, which is great. However, they are into their sort of later part of their careers. And I think it's important that we need to um, the colleges need to become more aware of this, train new medical practitioners, and I believe nurse practitioners have an important role to play in this, and multiple um, models of care should be available to patients.
There are a number of barriers to care, and I think it's important to emphasize there are more patients out there that need and want OAT than currently Australia is able to provide based on current prescribing levels. So, I mean, we need to think about what those barriers are. So, you've alluded to the differences in jurisdiction in terms of policy. You've alluded to cost, which is now reduced as an issue. You've alluded to the aging cohort of
Hmm.
prescribers and a lack of new
Yes.
prescribers. But there's also the issue of stigma, isn't there?
Exactly, and that's I think something that I have experienced over my time um, in this treatment space. Then the stigma amongst healthcare professionals that they do not want to
Yeah,
see, um, substance use disorder patients in their practices or opioid use disorder patients. However, most of these GPs are quite happy to prescribe the full agonist opioids, and I do believe
yes,
they have a role to play in acute pain. But yet, when the
yeah,
conversations and I know you have done many of these educational evenings where you were trying to encourage more GPs that this is can be done. It is easy. Um, and not all patients are complex. And that's why we do have
yeah,
specialist pharmacotherapy services right across the country where there are specialists and they've got more time to, stabilize the patient. However, there are cohort of patients, I should say, that are getting treatment in general practice and if they require any other medical needs. And that's the challenge that
yeah.
we have. I mean, I know that in regional and remote areas there are no prescribers.
Nor are there dispensing pharmacists. That's also becoming an
Correct.
issue as well. But
Absolutely.
I view opioid agonist therapy as no different from managing diabetes. You have your simple,
Sure.
basic patients that you can be managed in general practice. You
Yep.
have a shared care model with specialists where
Yes.
you collaborate to manage patients of a more intermediate and high complexity. And the most of those patients who are of highest complexity and severity, then they're managed by
Hmm.
specialists. But unfortunately, that's not the case. And I mean, certainly my experience in working in specialist clinics is a lot of the patients in my specialist clinics
Hmm.
could really be managed by GPs in the community, but we lack GPs to actually take on that challenge. Now, I mean, for those listening, I mean, Meducate does offer a Mathod Plus course, which is designed to complement the training that is provided by the Victorian government and its Mathod training. So Meducate itself does have a training course, but training is not the only answer. I mean, what other providing knowledge is not the only answer to this issue. What else do you believe we should be doing as a society?
Totally agree with you, Fergal. We have done a lot of training and we have general practitioners attending the courses that are available. And however, when they leave the full day face-to-face training or they do their online training modules, they are not, initiating treatment. I think, Fergal, we need different models of care. I think we need to look outside that what else, which other healthcare professionals can we utilize to provide care for patients? I do believe that nurse practitioners play a very important role. In particular, as you know, in Victoria, we have nurse pracs that are managing up to 300 patients, which is great.
Yeah.
I think community health centers need to, be ramped up because general practice, one of the biggest barriers that I used to hear all the time is that I don't want to see those patients in my practice. Well, what else can we do on a state level or on a Commonwealth level that we can get medical practitioners to work in community health centers with a team around them, like a pharmacist, a nurse, and others, to be able to provide a holistic care?
Yeah. I think that's an important point, that a lot of people blame general practitioners, but we have to understand that general practitioners, for the most part, are working effectively solo in an unsupported environment and potentially dealing with very complex patients. So I think this idea of community clinics embedded within which would be multidisciplinary teams where there is that kind of level of additional support that complex patients and GPs need. I think that's a very good way for the future. So what do you see that happening anytime soon?
I think I'm hopeful and I am optimistic, and I do hope that jurisdictions but we all need to work together. Like the colleges need to work, the state government, the community health centers, and I know the great work that our patient advocacy groups are doing, and also the peer-led groups are doing. I think we all need to work together to provide the best treatment options for patients in a multidisciplinary approach. But I believe a patient-centered care in all treatments, I think we're going to get patients, we're going to get better outcomes.
And that's what we want, isn't it? So one last final message of hope, Tarek. What would you say?
I'm going to reiterate what I said earlier. I am hoping that our conversation today is not to criticize anybody or any jurisdiction, is to really have a good critical mindset that are we meeting the needs of our patients today? And is our policy or are our policies patient-centered approach?
Mr. Tarek Amiri, thank you so much for your time, wisdom, and expertise on this subject. Thank you very much.
Thank you, Fergal. Thanks for your time.
That's all for today, folks. My name is Dr. Fergal Armstrong, and this has been Cracking Addiction.